Welcome to this next installment of Live Well with UCI Health. I'm Ryan Manno from Coast 103.5 and iHeart Radio. And today we're putting the heart in iHeart Radio. I would like to welcome Dr. Ailin Barseghian, board-certified cardiologist here at UCI Health. Welcome. Thank you.
Thank you for having me.
It is lovely to meet you. And I want to come up like straight out and just front load it with some really intense facts that I didn't know until we sat down. Heart disease, the number one killer of men and women in the United States.
That's right.
Listen to this. Every 40 seconds, someone in the U.S. has a heart attack. Every 40 seconds. Every 34 seconds, someone dies of cardiovascular disease. I know it affects men more than women. We're going to talk about both. Let's just start with what are the symptoms of a heart attack?
Most of the time, classically, we think of the chest tightness, chest pressure, elephant sitting on the chest, radiating to the arm. But oftentimes, that might be a prescription for men, but for women, it could present not only as chest pain, but sometimes just jaw pain or back pain, neck fullness. And these are very atypical symptoms. The other non-typical symptom is indigestion.
Okay.
Now, typically, if you eat and you have heartburn 30 minutes after a meal, that's probably real indigestion. But if you have indigestion after exertion, that might be a red flag for heart disease.
That's really good to know.
Yeah, and sometimes just extreme fatigue and nausea can also be a presenting symptom for women.
Yeah. Why is that not more widely known? Because you do, like you said, you only think about like the arm, right? Like it's just kind of, yeah.
We discover these things when we have research that includes a broad spectrum of people, including women. We realize that the symptoms presentation are differ, but we have to study them to really pick up on these cues.
Yeah. Are you finding that heart disease is becoming more common in women than it was ever before?
Heart disease has been prevalent. What's different about heart disease in women is that we're protected up until menopause. After menopause, we catch up to men in terms of the amount of heart disease that affects women as it does in men.
Why? Why is that? That's
estrogen,
fascinating.
Yeah, estrogen is protective. It keeps our vessels pliable, keeps good cholesterol up and bad cholesterol down. It keeps blood glucose in check and insulin resistance at bay. But once perimenopause or menopause hits, estrogen declines. And so now we have a risk of stiffening of the heart vessels. We have an increase in bad cholesterol, LDL. We have a decrease in the good cholesterol. There's an increase in belly fat, which is visceral fat, and visceral fat has been described as metabolically active, which means it's inflammatory, and that's a risk factor for heart disease.
Yeah.
So things change when estrogen declines.
That is interesting, huh? Okay, so what questions should someone that's watching this right now that, I don't know if it runs in the family or they have concerns, what questions do you think are good to start with? You go see your primary care provider, right? Like, what do we want to know?
I think asking those questions are so important. Ask your primary care provider, what is my risk of heart disease? Am I at increased risk because of a family history? You can ask them, is there any testing I could do to check for early buildup of plaque or atherosclerosis? And if you have any symptoms like shortness of breath with exertion or chest tightness or chest pressure, ask what tests you can do to get those assessed. If you smoke, ask for ways to help you quit. That's very valuable. There are a lot of resources for this. If you're thinking about conceiving or pregnancy, we've identified that maybe we're not risk stratifying patients who are becoming pregnant and they're going into pregnancy with high risk features. And ask your doctor, what are my risks when it comes to pregnancy and what can I do to improve them?
Yeah. What are the biggest risk factors for cardiovascular disease?
High blood pressure, high cholesterol, diabetes, smoking, and family history. These are the main 5. There's additional risk-enhancing factors, but these are the ones we focus on primarily.
What is microvascular disease?
Microvascular disease is an area of interest of mine. So there is an entity of angina or chest pain that comes from the heart, but it's not from the typical heart arteries that form plaque. These are the tiny little blood vessels that go inside the heart muscle. And when they don't provide enough blood flow to the heart muscle, you get chest pain and chest tightness, just like you do when the big arteries clog up. So we are looking for ways to identify this type of heart disease, and we do that through specialized testing, particularly at UC Irvine. We do the specialized testing, but just recognition that don't stop at just looking for blockages in the big heart vessels. If you have persistent pain, and sometimes this pain just goes on for months or years and never gets identified, we want to look for other causes.
Do you find that a lot of patients that, end up having something wrong, a delay coming to get tested and checked? Yes,
absolutely. Women in particular.
Why?
They're looking for the typical chest pain symptoms that we put out there, chest tightness radiating to the arm. But with these non-standard chest pain or atypical symptoms, there may be a denial in that their symptoms are coming from their heart. And so there's a delay in seeking care. And that is one of the major delays in care in women, and also in elderly and diabetics. They also have atypical presentations. But once you hit the door in that emergency room and we suspect you're having a heart attack, we are working really hard to get you to a cardiac cath lab to do an angiogram and open up that blood vessel within 90 minutes, because time matters.
Yeah.
And the preserving heart muscle matters.
You mentioned the testing part of it. Can you talk about what that testing entails? Like the testing you guys do here at UCI Health? Like what is it? What is the test?
Sure. If we always start with a history, getting a proper history and really seeing if there is elevated concern for heart blockage. And if there is, a pretty standard test is a stress test, and that comes in different modalities, but the appropriate stress test for you. And of course, if that's abnormal, the next step is the gold standard, which is a cardiac catheterization to look for heart blockage. So let's say we do that test and there is a heart blockage, then we would put a stent, which opens up the blockage. But if we're really convinced you're having chest pain from the heart and we don't see a blockage, then we can move on to that additional testing that we do to look for things like microvascular disease or vasospasm of the heart arteries. These are all causes of angina or chest pain, but not due to obstruction.
Yeah. I work with there's a guy that works on our show. He's like a hypochondriac, I think. I don't know. But he's always talking about, like, I feel like I'm shaking and it's like, sometimes, and then I go, and wait, does my heart, it's like it's a weird thing. Sometimes if you get in your head about it too, you're like, I should go get checked. But I think everyone should go get checked if it's a concern. Yes.
I think one way I advise patients is if you go for a walk and exert yourself and you feel good or better, it's probably not coming from your heart.
Okay.
Because the way we check for heart-related pain is by getting your heart rate up on a treadmill, for example. So if you can exert yourself and your pain is improved, it's probably a good sign.
Okay. See, that's a great tip. That's really fascinating. What kind of care do you guys offer here at UCI Health, that other places don't or can't?
As an academic center, we have a wide spectrum of not only specialists, but programs. So we can treat patients from advanced heart failure to cardio-obstetrics, which is in partnership with our OB-GYN, so that's very related to women's heart health, as well as integrative cardiology, preventive cardiology. And we partner that up with our research. We have cutting-edge research. We have innovation incentives. We look for the latest tools and the best treatments that are out there to give to our patients.
I love that. Let's talk about prevention. What can people do to obviously not smoke, right? But what other things can someone just do day to day, to get ahead of it?
The easiest thing that I've learned is making a healthy choice every time you're faced with a choice. So you're
my God.
Yes, look, you have two choices,
Okay.
You've got the vegetables or the fried food. Take that vegetable over the fried food. Just make those simple steps, make healthy decisions every day. And we always recommend regular exercise, moderate intensity, at least 30 minutes a day, 5 days a week. That is an American Heart Association recommendation and widely recommended. Also, it's important to know your numbers. know your blood pressure, know your cholesterol numbers, your glucose numbers. So once you quantify these and you put a label on them, I think it's easier to work towards improvement. Of course, if you're overweight or obese, weight loss is recommended. And then the rising concerns are things like better sleep, reduction in stress, which are bigger things to battle, but definitely something to keep an eye on.
Yeah, the sleep and the stress are probably like the hardest ones to control, right? You can eat the vegetable, but if you're stressed and not sleeping.
That's right. And again, labeling these things and recognizing the stress at least lets you work on it. Sometimes we're just not aware.
As someone in your position, how is your heart? I'm serious. Do you take extra good care of your heart?
I really do my best. I check my cholesterol regularly.
Yeah.
I try to make healthy choices, but I'm not perfect. I think that's the difference, is that I'm constantly trying to learn ways to get around sort of the mental pressures to make bad choices.
Yes.
And so it's hard work, but I try to live a healthy life, and that's just important to do.
Yeah, because you see everything, right? So you see it.
I see everything.
Yes.
And to be honest, sometimes I'm just wondering, what do my arteries look like when I do a procedure, a cardiac cath, or get a test done.
Let's talk about familial heart disease. Just a quick story. One of our colleagues, our coworkers, his mother passed from a heart attack at 41. He was 8. He's become very passionate, we'll say, to make sure that his heart is not at that same risk. Gone through so many tests. But what about somebody who's not doing all of that? What are some things to know about the familial risk?
The definition for premature heart disease in the past has been considered any male family member that's had a heart attack at less than 45 years of age, or any female family member, first-degree relative, that's had a heart attack under 55 of age.
Okay, so 45, 55.
45, 55. So if you have those parameters in your family, then we recommend early assessment for heart disease. That being said, if there's a first-degree relative, a male, for example, a brother or a father that's had a heart attack at less than 55 years of age, or a female less than 65 years of age, I would consider that to be on high alert regarding what to do. So same things that you could do is make sure you've had your cholesterol checked, your blood pressure checked. And there are imaging modalities that can be done. For example, a coronary calcium score has been well validated to risk stratify a patient into either low, medium, or high risk. And this is a CT scan. It's a very quick CT scan of the chest looking for calcium in the heart arteries, which is a surrogate or a marker of heart plaque buildup. And if you have the presence of that, it essentially just means that you would treat your risk factors more aggressively and perhaps get on cholesterol-lowering therapies earlier. And this test has been validated for those 40 and above. So if you're 40 and above and you have a family history of early heart disease, consider discussing that with your primary care doctor.
Really good. Thank you so much, Dr. Barseghian. We appreciate the time. Thank you.
Thank you so much for having me.